Okay, so thank you, Greg. And, we've heard about heterogeneity. Those are very difficult words to understand what they mean. I'll only have 3 words for you to remember. They have been talking about the bug. That's very difficult to confirm whether it's there or not. But the other thing for you to remember is if a decision to treat is made, the other thing you have to worry about is the drug. You have to make sure that there's enough drug. And then, Greg, you mentioned about the Z-score. I will talk about those 3. So there was work that was done here in Cape Town by Kit and Deda's group, by Laura. What they did is they were really worried about whether what we see in the lung, does it really tell the whole story? And they took patients that were going out for surgery, and they measured the drug concentrations from the cavity all the way to normaline tissue. And they also measured, did something good. She also measured the MIC of the drug. And you will understand why that matters. So what she found out was that when you get to the cavity where most of the bug is, you don't have enough drug there. And then when you try to characterize the bug that comes out of the lung, it's not always the same with what we measure in patient's sputum. So that's a problem with the bug. And then, so what Scott then and Stella did was they said, well, so in patients with MDR-TB who do not have rifampin is the main sterilizing drug, what really are the predictors for the patient's outcome? And they found out what we had seen earlier on, that the concentration of rifampin matters. And in this case, these were patients that were rifampin susceptible. And they also found out that the concentration of the quinolones, which are the other sterilizing drugs, also matter. So I also asked the same question, that do drug concentration matter in patients that we say have lung damage? And we measured, I measured the Z-scores using pulmonary function state. And I want to draw you to the 3-year time point, where you will see that patients that had 2 standard deviations away were more likely to die than those that had normal pulmonary function state. We had followed these patients for over a decade, which means that, Greg, probably during treatment, we need to start looking at those Z-scores to come up with our endpoint. And we then said, so is there a correlation between days that we treat, days that are taken to culture negative, and lung damage that is measured at 26? And we did find a correlation regardless of whether the patient survived or died. So it meant that even those who died, they had a steeper relationship. And this is an analysis that adjusted for the cavity. So although we have known for a long time that patients with a cavity have a severe disease, what we are seeing here with spirometry is that as long as the Z-scores are not where they are supposed to be with your spirometer, probably we need to be more aggressive in our treatment. And that relationship is significant. So there's the bug, there's the drug, and there's the Z-score from spirometry. Maybe we need to think about those things. Thank you.
Thank you. Let me just point out that that point, I think, is really, really important. In trials that are being done, like by the ACTG, that are just not PTLD trials, but just antimicrobial therapy trials, there are potentially strategies we should be thinking about drug exposure that even among just the anti-tubercular therapy drug trials may impact PTLD. So whether it's modeling PK to try to modify drug exposures to decrease PTLD risk, I think that's amazing. Sometimes we think the HETs need to be immunomodulatory, but perhaps it's just drug exposure of anti-tubercular therapies as well. So thanks for that. Yeah.